So now we request Dr. Subroto Mandal to present his case of rescue PCI in left main.
Good afternoon, respected chairpersons and dear friends. So my case, as you told, that rescue PCI to left main. So before going to the issue, left main, sometime what happens in many cases we see that left main is, it may be very simple as normal PTCA, but the important part is that how you take a decision and timing of intervention, timing of decision, and these are things I'm going to throw today. This is in support of your dear friend surgeon, and what are the measures you have during the emergency. So before going this, I want to, every case is start with the history. So I want to start with the story like that, what exactly happened with me. About 9 p.m. Just when I gone home, after that I got an unknown call from private number where you cannot see the number. So it was some minister from Andhra government that he has called me that you go and see some of the patient which is admitted in some private hospital. So I, as a colleague, because the hospital where it's admitted, he was a senior to me, around 15 years senior. So with his patient was there. So now I just as a courtesy, I cannot go with a permission, without a permission. So he has arranged the same that he has called. I got a call from the hospital to see the patient. So patient was admitted to private hospital. Yeah, and when I entering the hospital, there was a big crowd, around 4,000 to 5,000, because he was a minister's brother. So it was a very difficult situation. So I got there, and relatives are so aggressive, and this situation was like that. Then after that I got entered in that hospital, and there's a, what I seen is, I discussed with the senior that what is exactly you want me to do. He was telling this, he was happy that I was there, because at least 2 consultants have seen the patient and something is gone wrong. It will be easy for him to manage the scene. So that was the situation I have gone this. The patient was history-wise 40-year male. He is always hypertensive and chronic smoker. He has had extensive enteroendometrium 7 a.m. 11 a.m. he has gone to the hospital. He has given Elaxim 40 mg, and he has repeated history of the VTVF, DC, CPR, everything, and gone into cardiac shock, and the patient was on ventilator. So no outputs in the since morning, the admissions. So what I have done? So after brief history, what I have seen the pulse. There is no pulse palpable. BP is not regardable. This and EF is only all parts are hypocognitive except inferior. Some part is moving. That is it was done by me, and it was an all support whatever best possible. Dopamine, dobutamine, noradrenaline, everything. No outputs since the morning. So now after that, what was the question about my mind is that, first thing that prognosis to be explained that I have done, and second thing explain the risk. There is a normally doctor feels there is a safe feeling. It gives a safe feeling to me as well, that I have explained everything to the patient. And my problem is that now what to do. This is the basic problem what I faced, not the left main procedure. So if I ship the patient to other hospital, then what will happen? It will be a burden to me, or as well as that whether it is going to do something as shift to either I have to shift to ICCU, or I have to shift to cath lab, I have to do rescue angioplasty, I have to do angiography, IIBP, medical, whatever, because these all are going in the mind that what exactly I can do for the best of the patient. And moreover, there is a large crowd outside the hospital. So then I have decided that whatever it is, I have directly take the patient to cath lab. No, I will not take patient for the ICCU or any other hospital. So then after that I have shifted to my center, and this is the first, this is exactly, if I say, this is not the first angiogram. Because when I seen that first that taken one, that was totally blank, just only aorta I can see. So blindly, just taking a risk of, I have taken, first I have taken right side, that is totally normal. The left, it is this is the, after putting a wire blindly, that I have taken a first injection. This is the first injection. Then gradually, that the problem is that in between there is another issue. As soon as I am putting this rest totally, if I engage the catheter in the left main, patient is totally there is nothing I can see also. So this was a very difficult condition, as well as second thing that whenever putting this wire is also coming out 2-3 times. So I put a stabilization for this. I have two things. One is stabilize the patient, and I have to put IIBP immediately and rescue PDC. So after that I put 2 wires, that to establish the patient, and gradually I start with the intervention. So that was another problem, is that in between patient is getting VTVF. Because of this, I don't know the reason, maybe that because ischemias and all the things. So and these 2 things I have done. My colleagues, I asked my colleagues to put simultaneous IIBP in other side from other left groin, and we have started this. Then catheter will establish, we put 2 wires to establish the catheter, and as soon as I want to put the flow across the left main, so what I have done that I taken a 2.5 into 10 balloon and I will dilated that. Then after that I just get a little flow. So that was a good moment for me that patient just something has started. And then after that I just start the procedure, means one by one gradually I'm taking up. And then gradually I've taken the stent 3.5 into 18, and but because I was that time it's so hurry up, means the situation was so bad condition for me to take a decision what to do, what not to do. So it was a very lot of things I may have missed or something that I've deployed. And this is the post dilatation, and then you can see this the results finally, and this is the this result ultimately. So this is the pre and post. You can understand, you can see that. So my what exactly I learned from this case is that first of things, don't afraid of the left main. All left main are not the same, and you can manage it. Left main is not important. Important is taking a decision, what to do, what not to do, and careful when you are at risk. Decision important. Timing of intervention is important, and crowd should not take a part in your decision. These are 3 things I have learned from this, and thank you for your patience hearing.
That patient was admitted in another hospital and shifted to your hospital.
No, I was shifted to my hospital.
I mean, during the transport, he was hemodynamically stable, or
No, it was totally not stable. There is no pulse is not palpable, BP is not recordable, and just with that, that is the taking. I am talking this point is that decision making is important. That what I should do in that point of time, whether I should shift the patient, either should wait for the stabilization, wait for the BP to come out, or what I should do. This is the point where I was very confusion, and that's the point I want to learn, that taking decision is more important, and the point of time what you are treating the patient. Follow up. After one thing is within 2 hours of the patient, he has started putting urine, and which is fortunately or unfortunately, patient was extubated, self-extubated. Patient was taken out on own within 2 hours. That was a good thing I want to say.
okay. Thank you.